now to the next presentation, which is now the Gates Foundation presentation of their zero-dose learning agenda. We'll have Tove and Mike presenting. Mike is not there? Yeah, okay, he's coming. So we're going to have 30 minutes presentation from them, and that's going to be followed by a 15 minutes presentation by Deep Thacker, which is one of their grantees, and a top-rated abstract author. Like I got high marks in I think 2 abstracts that you submitted, and both of them were really highly rated. So it's a good opportunity to kind of learn a little bit more on how this implementation research has been implemented, and have this visibility of the Gates learning agenda. With that, Tove, the floor is yours. Thank you very much.
Well, thank you, Gus. And just to introduce myself again, I'm Tove Ryman. I'm with the Gates Foundation, and I lead our zero-dose learning agenda. I'll be presenting on behalf of all of our grantees and partners working in this space. I'm presenting with Mike as well. Next slide, please. Do I have someone running the slides? Okay. So just quickly to give a bit of an overview around our work, we're striving for the same goal as everyone else in this room of a 50% reduction in zero dose by 2030. And we're doing this in a 2-year sprint where we're looking at sort of 2 core questions. One is around trying to think about how we can support Gavi in the shifts and changes that they need to be able to meet this goal, as well as trying to identify what is our own comparative advantage in terms of working on zero dose. And we're doing this by 2 complementary work streams. The first is around subnational programmatic implementation. So this is around really digging into better understanding the drivers of why there are zero-dose children, and then testing interventions in order to be able to reach them. The second is around looking at Gavi funding mechanisms and implementation, and thinking about opportunities for adaptation. So for today's presentation, I'm going to touch on our subnational programmatic implementation work, and Mike will then present on the Gavi funding mechanism portion. Next slide, please. Great, next slide. So our work varies in terms of how we're actually doing implementation, but I think it's important to note that despite the variations in approaches by partner and context, all of our projects include some common elements, which are articulated here. As I mentioned, we have a strong piece around diagnosing drivers and root causes of zero dose. All of our interventions are being developed through direct engagement with caregivers, communities, health workers, government officials. We also have a strong piece around iterative cycles for testing and refining interventions, so a continuous learning piece of our work, a strong focus on gender considerations, and as Logan was talking about earlier, we're capturing cost information for our locations. Again, this is a 2-year project, so we're looking for indications of this work leading to sort of better targeted or effective programming, but we know that it's not realistic probably to see changes in coverage. So just want to be clear about sort of our ambitions there. These projects are located in subnational areas and in areas of high zero dose burden in 6 countries. Those countries are Nigeria, Ethiopia, Pakistan, India, DRC, and Kenya. On the next slide, please. These are the 31 subnational locations we're working in. And I'm not going to go into the details of these here, but what I would like to point out is the fact that we do have contexts that cover urban, rural, as well as rural remote. I think it would be fair to say that most of our sites would not be considered fragile or conflict settings, but you'll be hearing from my colleague Katie later today, doing risk work, which is focused on a bit more of those contexts. Next slide, please. So we have some motivating hypotheses that are driving our zero-dose learning agenda, and we've organized these around the IRMA framework. Given where we're at today with our work, I'm really going to be focusing on the identify part of this because that's where we have findings to share. Otherwise, I'd be talking about hypothetically, what are we planning to do? But just to share a bit about these, in terms of identify, we have an ingoing hypothesis that the current identification for zero dose is not sufficiently granular, and it's not considering the full range of drivers, gender, intent, and some of these other pieces that we think are so important for really understanding why there are zero dose communities and zero dose children. In terms of reach, we have a hypothesis here around the fact that interventions are insufficiently tailored to the local drivers and contexts, and that this leads to ineffective or unsustainable interventions. And for the measure and monitor, here we sort of have a hypothesis that these nationally driven, sort of inflexible mechanisms really lead to cookie cutter types of interventions that actually don't reach the zero dose children that we're aiming to reach. So again, I sort of want to share the big picture of how we're thinking about the work and where we want to focus. But today's presentation, I'm really going to talk about the drivers or identify part of our work. Next slide, please. So we have learning questions specifically around this identified piece. And I've kind of grayed out the ones at the bottom because these are questions for which it's too early to tell. But I'm going to share some preliminary data for our first 3 learning questions, which are around what are the drivers of and causes of zero dose in given subnational locations, the degree to which they vary across locations, and how gendered factors appear. So I want to be clear that these are very preliminary findings. We're actually in the midst of doing much of the analysis right now, but I'd like to take this opportunity since we're meeting to share some of what we're learning. Next slide, please. So quickly, in terms of our drivers data collection, again, across the country or across the sites in which we're working, the approaches taken by grantees have varied, but we have both done primary and secondary data collection. Most of our service delivery data is using HMIS or administrative systems, as well as capturing healthcare worker perspectives, typically through interviews. In all of our sites, we have captured caregiver perspectives through primary data collection, either surveys, focus groups, or interviews. In all cases, caregiver defined as the mother. In a handful of sites, we've also captured data from fathers and mothers-in-law as well to try and cover sort of the broader spectrum of perspectives. Next slide, please. So we have organized our work using the EGH vaccine delivery framework, which has 3 domains: intent, access, and readiness, and then subdomains within those. And over the course of the 1 year that we have been working, we've actually identified some limitations of this framework. And we're beginning to think about what an updated or revised framework might look like. So I share here sort of a preliminary schema visualizing some of the things that we think aren't adequately captured in the current framework. And that's to note that we really see how important the linkages between intent, access, and readiness are. And so those arrows are really important. We also recognize that readiness subdomains of supply and workforce don't sufficiently capture a lot of the service delivery considerations that are so important for, excuse me, these zero dose families. And also that prior experience is a prior experience with immunizations or health services is a really important part of intent. And so wanting to call that out more explicitly. So I just want to mention this because today I'll be still presenting our findings around intent, access, and readiness, but just to note that the service delivery and prior experiences will also come up in some of ours as well. Next slide, please. Can I get that? Thank you. I feel like this slide around kind of our headline around what we're learning in terms of drivers and root causes is so similar to the presentations that were given earlier today, University of Montreal, the presentation by Sabin. When we look across our context, it's so clear that most of the zero dose families are living in contexts of multiple deprivations and vulnerabilities that really impact how their day-to-day experience, as well as the experience of the healthcare workers who serve them. And we see big catastrophic factors that prevent these families from easily accessing services or availing themselves of services, as well as multiple cascading factors that make it challenging to be able to have their children vaccinated. And I think for us, this just really important, or highlights the importance of understanding what are really the root causes from multiple different perspectives. One of the other things that we saw, and again, it's very similar to what Mira presented earlier today, was that much of the data that we found really is related to intent and access. And I think that could be for a couple of reasons. I think one, a lot of our data came from caregivers who may or may not actually have a lot of experience with health systems, so they may not have a lot to report around service readiness. But I think there's also a piece here around when you look at the types of factors within intent and access, many of them can actually be traced back to service readiness pieces. So I'm curious if that's what others are seeing when they look at what are those actual root causes to some of the intent and access challenges. Next slide, please. So across our sites, we have used human-centered design approaches to try and better understand the perspectives of healthcare workers and mothers. And I thought that I might present some of the personas here, just because, again, I think it's a really nice grounding way to be reminded of what are the barriers and challenges for people to be able to access services. So here's just a couple of quick examples. We have Rabia, who is from Pakistan, a migrant mother living in an urban area. Her children were born in unregistered private facilities that don't offer immunizations. And so she was never given a referral to receive vaccines. And when the community-based vaccinators try and approach her, her family isn't interested in engaging because they see it as part of sort of a foreign agenda and don't have a lot of trust in the government. Another example from our Ethiopia work is Zabunesh, who is a mother of 3 kids. She faces a lot of economic hardships and limited access to health facilities. She lacks social supports. And even though she believes in the importance of vaccines, she faces a lot of barriers in terms of long wait times, unwelcome health workers, and lack of transport money, which she needs to request permission from her husband to be able to get to go take her children for vaccines. And then we have Vinita, a ASHA worker in India who has a target population that's 3 times what it should be. She also works in an area where her faith is different than those that live in her target area. So when she goes to visit and try and mobilize families before an immunization session, she is unfamiliar with the community's beliefs and practices, and thus faces real challenges in terms of trying to engage hesitant families. She's had families that have rudely asked her to leave. She's been accused of making her children in her community sick because of the vaccines. And so again, these are just 3 examples. Nearly all of our projects have put together personas that they have used to try and help with this process of distilling down what are the drivers and thus what are the interventions. And so wanted to just share a few of those here. I can go to the next slide, please. When we begin to sum these across all of the sites in which we're working, here are some of the initial themes that we're beginning to see. We see gaps in knowledge and awareness that particularly stem from missed health system touch points, as well as breakdowns in the community engagement. We see concerns around side effects. In most cases, it's not safety, although in some cases it is. And it's mostly rooted around the challenges of being able to seek care and manage those side effects. So, and the implications to the family for when children have fever or other things. Caregivers agency, competing priorities and time constraints, and the indirect costs of vaccines in terms of transport, lost income, childcare needs. And then for vaccinators, they're overburdened, undercompensated, and minimally supported for the work that they're doing. And we see in some cases, but not actually all of the locations where we're working, breakdowns in basic service capacities. So these are some of the initial drivers that we're looking at. But we really think that there's continued need, and our teams right now are working to actually dig deeper and understand sort of what are some of the root causes underneath these. So we have tried to, again, take a very sort of person-centered view around recognizing the woman or the caretaker, as well as the healthcare worker, and what are what's the underlying causes that are related. Oh, sorry, next slide. Apologies. I'm moving faster. Okay, thank you. So looking at both the caregiver and the mother, and sort of what are some of the interplay between these two individuals. You can take next slide, please. We see how these factors, when you begin to dig into the root causes, we see that there's, again, some really important causes, and they're linked across both the women and the caregivers. So there are things around how, for example, healthcare workers don't think that parents want to listen to them, and parents feel like they're being disrespected and not treated well by caregivers. And so there's interplay across the mother and the healthcare worker. If you can give the next slide, please. We also see that this caregiver and the healthcare worker live in a shared context. It's really important. And I know context has come up as being critical across several of the other presentations that we had this morning. But we see these contextual pieces impacting both the caretaker and the healthcare workers' ability to be able to both avail and provide immunization services. And so those are important things around marginalized populations, challenging terrain, entrenched gender issues, and things such as this. If you can move to the next slide, please. So the second learning question that we had was around how much variation we see across sites. And again, we've got 31 subnational areas that we're working in. When we look across these, there are some common drivers of zero dose. And those are around concerns of these post-vaccination side effects, particularly fever, abscesses. And this is around challenges with accessing treatment and the consequences of those, missing out on work because of that, and the potential response from husband or spouse. And again, gender-based violence has come up here as a challenge. So this is something that across every site we've worked in has come up loud and clear. And I think in some ways has come up in a bit of a different way than I think we typically talk about AEFI. Another example across all the sites that we work in is around the day-to-day challenges of meeting basic needs and how this often takes priority over vaccination. And so, these are caregivers who have to decide between daily work, wages, versus being able to take their children for vaccinations. And so those are, again, common across all. But then when we look, there are some drivers that are really greatly shaped by the context, specific nuances. And so thinking about sort of the context in which they live in, we see some pretty important intersections in terms of demographic context, urbanicity, and health system context and culture. And I'll give kind of 3 examples of where we see really big differences. So in Pakistan, polio workers and parents feeling very pressured around polio is coming up as something that we're not seeing in other places. In DRC, we're seeing the importance of some very influential religious leaders around vaccination decision-making. And in Ethiopia, an example is one of the worredas in which we're working doesn't have a health facility. And so it's a 30-minute ride by taxi to be able to avail services. And so the costs there are a major barrier for caregivers. So kind of capturing the idea that these context differences really matter in terms of what the drivers are of zero dose. On the next slide, please. This is an example of some work that we're just starting to pull together around how to look at these variations more quantitatively. And so you can see on the left side, this is looking at how easy it is to vaccinate your child, that there's a fair amount of variability both within countries as well as between countries for a question like this. And on the right side, looking at vaccinator availability and looking at how that compares or the differences that we see across countries and states within those countries. And so we're aiming to do more of these types of analyses to sort of look at this variation both quantitatively and qualitatively. Next slide, please. So our third learning question we have some early findings around was, how do gendered factors occur and how are they experienced? And when we looked across all of the drivers that are coming out, we found that there were nearly half of the intent drivers that had a gender element to it, about a quarter of the access and a bit less for readiness. And so we certainly probably looked, our gender was a really key part of what we were focused on for our teams. But it's interesting to see across these sort of how the gender lens has come out. If you can go to the next slide. You will not be able to read the slide because I have way too much content on it. But the message that I want to land here is when we looked across each of our intent, access, readiness, service delivery, and looked at what are the gender barriers, we highlighted those in kind of this pink color. And I think what we were really, I guess, surprised by is that literally across every single domain and subdomain, with I think one exception, there are gender issues that were coming out as a part of that. And so we just found a lot of gender factors across our work. If you can go to the next slide. I've pulled out a couple as an example since, as I said, I know you can't read this. But when we look for intent, we can see, limited healthcare worker engagement with fathers who are ultimately the ones that hold the decision-making power. For access, travel and needing to ask husbands for money in order to be able to do that. Readiness, major gaps in vaccinator and CHW availability leading to overburdened or underpaid. And we know that these workers are typically women in most of the contexts in which we work. Session timing misaligned with when women caregivers could feasibly seek care if they're working. And then the disrespect and discrimination that women experience in the service delivery. Next slide, please. So I'll note that these challenges were experienced in a compounding manner at the intersection of poverty and social marginalization. And we really see this as underscoring the need. We know that a lot of these gender issues are things that are well outside of our purview to be able to address. We really need to think about what are gender responsive approaches that we can use to try and help minimize these. Next slide. So I've now presented on our preliminary findings, but I did want to share briefly, our team has reflected on the process that we used to ascertain these and kind of what worked well and what didn't work as well. And I thought I might share this just for others to learn from us. So just to highlight what I think are a little bit different in terms of how we did this relative to a typical coverage and equity assessment. It was only zero dose focused. We were hyper local. We emphasized kind of lived experience and context. We had a strong focus on root causes and gender. We found in talking to our grantees that centering on the caregiver perspective was very feasible and did lead to some different understanding and particularly greater empathy was experienced. I think a lot of people were surprised by the gender insights that were coming out. And again, especially how prevalent they were across all of the domains. Both the grantees and government officials that we worked with were actually pretty open to this different process in terms of taking a more iterative and flexible approach. But when we think about what was challenging or needed work, in some of these contexts, identifying zero-dose families was actually very, very difficult. We also saw a challenge of bringing together intent, access, and readiness. And I think in some ways we focused really hard on the intent side, and I think we might have lost track of some of the more readiness issues. I think that it just shows how hard it is to hold that really big picture. We maybe focused a little on the caregiver and have not brought in as many different perspectives, and that integration of perspectives that's so important. There was some concern around using secondary data due to quality concerns and a desire for more off-the-shelf tools and products for our grantees to use. Next slide, please. All right, so what next? We have a little bit of work to do to finish up some of our root cause work around identify. I think we see that there's some big themes that probably require some further exploration, particularly around kind of the side effects fever piece. But in the near term, we're moving over to the reach. And so identifying tailored and gender intentional interventions and doing this connected with immunization programs and Gavi. We're also going to be doing this in a way that brings a strong continuous learning approach, measures costs, and is testing some measurement approaches. Next slide, please. With that, I just want to thank everyone on, as I said, I'm presenting this on behalf of all of our grantees and the communities who took the time. So I just want to thank those. And then I will pass it over to you, Mike.
Great. Thanks, Tove. We can grab the 2 slides forward. So I'm going to talk briefly about the other aspect of our ZDLA learning framework, which we sometimes call the EAF grants for shorthand, but are really about how looking at zero dose from the grant operations and implementation side of things. So one thing just to step back is when Gavi came into 5.0, it came with the recognition that there had been a period of stalled progress on zero dose, that many countries had held or increased the number of zero dose children over the last period. And that was not for lack of care. The concept of the left outs were what preceded zero dose. RED and REC are fundamentally strategies about reaching neglected or underserved communities. And yet we hadn't seen the progress. So in addition to the push that we see right now, that I think we've heard so many good examples of today about what reaches zero dose kids, what is driving these issues, what can be done to address them, there is also a question about what is it about the way we work that needs to change? And that was the IRMA framework is one example of that. But as Tove has said, that's a more local aspect. That is hard for an international organization like Gavi to get more local, for national institutions like UNICEF and WHO, for partners that are mainly used to working with EPI, which has its strongest presence at the national level. All of these things suggest that zero dose work is not just a question of knowing what to do, but also thinking about how we do it. And so this work is designed to try and treat very specifically that question of how and what can we learn about what enables or impedes our ability to do this kind of thing. So our work is really focused on it looks at the Gavi zero dose centric funding. The HSS in 5.0 very much made a pivot towards equity, but the EAF and the mixed backsliding funds are wholly focused on zero dose. So we use that as our framing device, and that's what the investment instruments we focus on. The second is to really explicitly focus on coordination and organizational, like operational management systems, rather than in specific interventions. So really treating the how and the coordination of a package of interventions as the question, rather than the individual specific interventions themselves. And this very much overlaps with the work that was presented on the zero dose learning hubs and other things, which came out some of those points about coordination, about funding flow, about some of those things. But it is more narrowly scoped than those elements are, but it's designed to be complementary. Next slide, please. The way that we set this up was to structure it around what we called 15 learning areas, and is to try and say, like, what is it that we want to do? How can we look at the question of zero dose and try and extract some findings around it? So the grants are set up through the combination of the grantees, which I'll get into on the next slide, but providing direct supplementary support to the country on operationalizing and coordinating activities, but then also supplement that with their observations, key informant interviews, and engagement with the Secretariat and others around to identify enablers and barriers across these learning areas. And I'll quickly run through, and then cycling every 6 months, checking in on how has progress happened? Have these things been unlocked? Have new barriers emerged? Have the same barriers manifested? Have new enablers come into play? And I'll call out a few on the right-hand side. There are 15 total. There's a few examples from each of them, but I want to call out some of the three where we really focus. One is you can see the first 5 blocks are all built around IRMA. And we really wanted to do that so that we could draw lines between the specific type of work that is under identify, measure, monitor, and reach, and the type of investments or things that underpin that Gavi can or could invest in to support it. So maybe that's a coordination body, maybe that is a certain kind of guidance, maybe that is a certain kind of political engagement. And you'll see sustainability and political support comes through under a few of those there in that first part. Gender, we really wanted to call out that it is very easy to write gender into an application and to say that gender is going to be a lens. It is much harder because that is not a muscle that partners have trained, that governments have trained, that even institutions have trained on how to follow up on over the course of a grant and integrate it into the wider part. So we wanted to see, how does gender show up in the discussion? Is it on the agenda when you talk about things, or do we return to sort of reversion to the mean? And then coordination and learning. That's a huge part of it, particularly when we talk about the subnational part. How are we bringing in lessons of what the new learned information that comes in? Are we reprogramming grants in response to activities happening at the start? There's a really good point on the early sessions about we can do learning embedded analyses or something early in the cycle, but that assumes that you then change the programming in response to those findings. Do we see that happening in countries that are set up that way? Next slide, please. And I'll close this out quickly so we don't overrun time. We are very early in this cycle, in part because the EAF grants have been approved over the last year and a half. Disbursement has really only started in the last 6 months. And so in some countries are actually still waiting for their funds to be dispersed. But we have 4 countries where CHAI is implementing. 3 of them are EAF, which is Cambodia, Cameroon, and Uganda. And Indonesia is then implementing the mixed backsliding approach, which is a part of it's the INEY2 World Bank funding. It's a jointly funded initiative with Gavi. And then Village Reach is working in 2 of the highest zero-dose concentrated places in the world, Shopo and Hokitonga, which are 2 provinces. We are just about to release our first round of results of consolidating our findings, which is based on mainly applications. That is, because it's applications, going to look a lot in some ways like previous reviews of Gavi application processes that you see through the IRC, through Ipsos and others. Where things are hopefully going to get richer and deeper is when we get into the implementation. That's going to come out over Q1 2025, and then we cycle through. But what we really want to track through this is, what did we see in the application? Did we see those things pay out and those coordination mechanisms deliver in the first cycle and the kickoff? Do we see them hold as you try and maintain momentum on zero dose through the cycle? And the idea is we do this through mid-2026 to sort of cycle those results and see progress. And I'm happy to go into any more detail on this with people while I'm here this week. Thanks.
Deep, yeah, the floor yours now.
Thank you. Can we have the slides up, please? So while the slides are being put up, let me reintroduce myself. Good afternoon, everyone. My name is Dr. Deep Thakkar, and I shall be presenting findings, as Gus had mentioned, from both of our abstracts, as was suggested, because both these abstracts kind of explore the data on similar lines. Can we put this on full screen, please? So now the only difference between both these abstracts is difference in data sources and the difference in geography that is covered. But the line of exploration remains the same. And that's the reason I've kind of, it's not purely as I would present a scientific abstract, but in more of a story form and a chronological order, how we discovered, how we came to this conclusion. So the title I will get in the end on my last slide, why we are saying this. Can we go to the next slide? I think this changer is not working. Yeah, sorry. Okay. So before I begin, just to introduce the unit that I work with, so we work with as Uttar Pradesh Technical Support Unit, which was established under a memorandum of cooperation between Bill and Melinda Gates Foundation and the government of Uttar Pradesh. We provide embedded and integrated technical assistance to GOUP to strengthen health systems and improve RMNCH outcomes, including routine immunization. On the immunization, we created a routine immunization program management unit in 2020 during the pandemic. And this is where the immunization work kind of kickstarted for us. As part of the grant, we had 3 different diagnostic approaches, one of which was the rapid assessment survey, which was conducted in 2021. So this focused on the 100 blocks where our focus support is. So this was supposed to be a baseline survey, and as Ali mentioned earlier, so it wasn't zero dose specific because the goal of the project was to improve full immunization coverage. But when we now retrospectively look at data and reanalyze it from zero dose lens, we have some interesting findings. So this covered 34 districts of the 75 districts in the state, and the primary sampling units were ASHA areas. So 444 of those, a few linked ones were added to because we were not getting adequate samples in those areas. So some of them had linked samples. Total mothers interviewed, so the caregivers interviews, I will keep on changing to mothers in the future because 99.9% of the respondents were mothers. So total mothers interviewed were 10,599. We also, because we did a linked survey, so we interviewed ASHAs of the same areas where the community survey was done, and also the cold chain points to look at the availability. Now this data collection was in 2021, immediately after the Delta wave that India faced. The overall coverage, if we see all basic vaccines, 68% of the population had received it, and the zero dose prevalence, what we found was around 5.3%. Now, as we do for any kind of survey, what we did next was look at correlations, which we were discussing earlier today. So I've not put everything up here, but the significantly correlated factors. So religion, type of family, mother's education. We had also information Mira on father's education, but it was not significantly correlated, so it's not mentioned here. The birth order and the economic status of the family. So this is all kind of well known. Generally, the next approach is to look at geographical concentration, which we did not find in the survey. But traditionally, as UPTSU, we have been using the effective coverage cascade to identify areas where we need to work on, because in the end, the research has to lead to implementation and to identify the gaps. This is a framework that has helped us a lot. Now, I won't go through the entire framework, but the first step itself, the service contact coverage, which was measured using 4 indicators, that has met the ASHA during last 1 year, received any information or service related to immunization, delivered at an institution, the mother delivered at an institution, or child received any other vaccine, any of the vaccines, in this case. The service contact came as 99.5%. And this was really, really surprising for us because our full immunization coverage or the basic vaccination coverage is 68%, while there is a very high service contact. So now when we look at it through zero dose lens, what we thought was, let's look at what are the services that zero dose children are receiving, right? So amongst those zero dose children, 70% of the mothers had received ANC services. 62% had delivered in an institute, not DPT or Penta 1, but other vaccines were received by 44% of the children. And if we see any contact, so either one of these 3, that comes as 87%. So on the MNCH continuum of care from pregnancy to childbirth and then immunization, 87% of the zero dose children or their mothers had been in touch with the service delivery system, the healthcare system. Now, after this, so we tried to validate these findings using the DHS data. So these are services received by women and children across 3 rounds of DHS, right from 2005 till the latest round in 2019-21. As you can see, the service not just contact, but the service received for ANC as well as institutional delivery was quite high. Immunization also, we see steady rise at the country level, at the state level as well, and zero dose prevalence has been reducing. What was interesting was almost 95% of the zero dose families had received any one of these services. So that was validated using DHS data. Now, after that, earlier this year, I think Meera and David were there. We were presenting about our digital systems work to the ERG. And after coming back, after presenting our work, what we thought was, let's check, do integrated or interconnected digital systems have a role to play in identifying zero dose children? So we use the same methodology for, we looked at 10 high zero dose burden countries, but DHS data was available for only 8 for the periods between 2015 to 2022. So the 8 countries are India, Nigeria, Indonesia, Ethiopia, Philippines, Pakistan, Angola, Myanmar. So we used the latest data set that was available and ran a similar analysis, but this time the indicators were 7. So ANC visits, institutional delivery, vaccination, vitamin A within last 6 months, birth registration, availability of vaccination card, and postnatal services. But out of these, we found that 3 indicators did not add much incremental value to any service contact. And that's the reason it has been dropped from subsequent analysis. But just giving the coverages for these 8 countries, we see a wide heterogeneity, like in zero dose prevalence from 6.1% in India to the highest being in Nigeria at around 34%. Of course, all of these surveys are from a different time period, but what is interesting is across these time periods, what you will see is across Asian countries, any service contact is higher than 90% for most except Myanmar, where it is 86%. Now, the coverage of individual services varies across countries, but any contact, and that is quite high in Asia. Even in the countries on the African continent, what we see is a coverage, any service contact, any contact of more than 65%. So, except I think in Ethiopia, where it is 64.2%, but a good service contact coverage that we can see. Can we go to the next slide, please? I think something is clicked there by mistake. Okay, so now just to put this in context of the previous slide that I had shown, I've divided this into the zero dose proportion into 2 parts. One is any service contact or no contact. So if we had to see the missed communities, so the ones in reds are the actually the missed communities where they are receiving none of the services, but a significant proportion of zero dose families have received some type of service contact. And thinking from solutioning lens, and which comes to my last slide on the recommendation, is there's a scope to potential to identify children, because the traditional identification has remained either geographic or based on some socio-demographic characteristic. Here we have an opportunity if we are able to track across, not just think immunization, but as a MNCH or PHC services. And if we track longitudinally a pregnant mother through her pregnancy and then a child, develop mechanisms, either paper-based or digital, there's a possibility to identify a significant number of zero dose children. More than 50%, which is our goal. The challenge still remains how to reach them. That is not covered because that will depend, as Tav was mentioning, this is the part where we are working on now, on understanding the why. Because these are families who were ready to receive some other service. And this is not just counseling or anything. They have received some kind of healthcare service. If one person can reach them, or we can reach them for one program, definitely we can reach them for immunization services as well. Understanding why they are not receiving these services is more crucial. The other thing is, those who are not on the radar, the efforts can be focused on the red section, which was there, the true missed communities. And that's the reason I go back to the title, which was missed community or a missed opportunity. It's a mixture of both, but then there are a lot of missed opportunities if we think from a PHC lens. The denominators that we always talk about, they are kind of hidden in the numerators of other programs. And that is where integration of integrated service delivery can help us identify. So there are a few recommendations. One, of course, I have mentioned either digital systems or paper-based systems which can track mother and child across a continuum of care. Another one is all of these information, especially in the country that I come from, it is available to the frontline worker, but they are not able to use that information. It's there in the ASHA's registers, it's there in the A&M's registers, but it is not designed in a way to efficiently use this information and identify these children and reach them. So that is another area that can be explored of how do we build capacities of frontline workers to use information already available to them. So thank you, that's it from us.
Thank you. Thank you very much. Yes, I see there is already some questions in the room. It's pretty exciting, this research. I'm sure there's going to be lots of questions. Mira, if you can wait a little bit, because I will start with the virtual environment, then I come back to the room. We still have, how much time? We still have 45. So we still have 45 minutes for discussion. We have time for everybody, hopefully. So let me start with some of the questions from the Zoom. One is about, I think this is a little bit of a kind of a criticism on kind of the limits of the IRMA framework, and about adding gender coordination, PHC integration, all of these other areas that we're discussing here today. I think the suggestion is that it does make a lot of sense intuitively. And do you see that as a challenge or an opportunity to move in this direction and expand a little bit the IRMA framework? I'm not sure this is a question for Tove or Mike or Deep, but opening for the panelists, if you think that makes any sense on like expanding the IRMA framework. If anyone would like to come in. Or of course, Mike.
I can take a crack at it. I think the IRMA framework is in some ways a project cycle. And it is a way of thinking about zero dose. And I think it is a very EPI and like implementer centric version of it, which is probably where the main value of it lies. Is the idea is you understand what your needs are, you implement against those specific identified things, you then monitor and measure whether you are making progress, and you advocate for the necessary sort of sticky changes that you want to retain. And then it's a cycle. And the problem with any of these type of learning project cycles is that we often don't see the cycle, like actually things stall out after the second phase. You implement and then you never monitor and you never advocate and you never loop back to check your assumptions. So in that way, I think it is actually a really big push in a lot of ways. The inclusion of the other elements, I think, speaks to the fact that IRMA and the EPI sits within a wider health system, and we need to figure out how we do more of those intersectional areas. And that's just health in general. So on the one hand, is it enough? No. Is it good at, I think that IRMA is a pretty good push, though, at addressing what is a fundamental challenge in zero dose right now. And what we need to think about is how that sits within a broader EPI strategy, and how that immunization strategy sits within a broader health system strategy that accounts for gender and those intersectional elements. So I think the answer to the question is maybe yes, but also No.
I agree that, I mean, they're even simple enough, right, for people to kind of think about their programs. And as from that perspective, I think is a very useful, like a project cycle. It's not everything, and it's not designed to be everything. And there is intersectionalities that needs to be considered. Maybe it's something that we can think about and be more proposal on those intersectionalities, crossing across Irma, but it's something that we need to probably think about. There is another question. There is one question that will jump for now because it's a lot of questions in one. The other question that is simpler, for Gates Foundation, I think it's for Tove most likely. There is a question about how zero dose is being incorporated into programming for urban immunization, especially with large population in India. I think there is an interest on like trying to understand what they're learning from the urban component, and especially in India, where like there is a big urban population.
Yeah, so as I noted, we do have urban sites. We have urban sites in India, in Pakistan, as well as Ethiopia, and I think one of our Nigeria sites would probably be considered urban as well. At this point, we have not gotten to the point in our analysis of being able to disaggregate to that point. As I said, we're literally in the throes of doing a lot of our analysis, but certainly recognize the importance of those urban and, as we were talking earlier, sort of like peri-urban areas as important places where we need to be focused on zero dose. So I guess more to come as we analyze that data.
Thank you. The next question is for Deep, related to what's the so what from what your research is showing. I think there is a surprise, like with the kind of the high level of service contact from most of like these zero dose populations across different countries. What's the implication here? And then could we think about a minimum viable product from a digital perspective? Like this is a suggestion adding to that. If you have already some perspectives on the so what, and then maybe you can comment like, do you see that as an opportunity for a digital solution?
So the so what comes from the narrative that we have been building over the past few years. Now, there's no doubt that these populations face multiple deprivations. They miss out on other services as well. But then that's the problem. Now, we started looking at this data because we wanted to find a solution. Like, how do we identify actually? Now, we know that these people do, but then the zero dose communities are well defined. Like the entire narrative was like 40% less likely to receive ANC services, but then there are some who are receiving ANC, some who are receiving other services. So the so what was it gave a different narrative, at least for us when we were looking at this data. And it was surprising. Actually, 95% in India, or even in Asian countries, about 90% service contact coverage amongst zero dose families. And this is, again, I'm repeating, amongst zero dose families. So that was a surprising, at least for me, it was surprising. Now, on the minimal viable digital product, I think digital products have to be contextualized. There cannot be a single product. If you wanted for EPI, you could easily do it. But the digital systems, like, and even I was just, because I wanted to reference this thing properly. So the WHO's digital strategy for 2022, the guidance on digital strategy 2020 to 2025, clearly they are also advocating that the digital systems are a part of a larger health system. It cannot be like immunization. We have got used to so much of vertical programming. I don't think any other program has a terminology for their digital records. We use EIR, not EHR. So electronic immunization records, not electronic health records. So that's the level of verticalization that EPI has been following. So the idea is the countries will have to contextualize it, either create an integrated system or interoperable systems, because the technology is changing really, really fast. health is the only domain which kind of lags behind in the use of technology. The financial sectors, the other sectors have been leveraging it like anything. So there are learnings from other sectors that can be taken, and interoperable systems can be created. If banks around the world can be connected, why cannot health record systems? So the thing is, you need those common identifiers to link data. So interoperable system or an integrated system, that's what the countries to choose based on their privacy laws and other things, what is available. So I wouldn't say there is a single product. The products would have to be customized, developed by them.
Thanks a lot, Deep. And just to clarify, the indicator you used to test for these kind of a continuum of care, I saw from India, they were mostly related from ANC care, but in the other countries you did this validation with the DHS. Did you look to other programs as well? Like what's your definition of like a service contact?
So for other countries, we have used only 4, and again from the MNCH spectrum, that is institutional delivery, ANC visit, vitamin A within last 6 months, and any other vaccines. Because we are seeing a lot of children are receiving some other vaccine, but not DPT1, and that's the reason getting labeled as zero dose children due to the technical definition, but they would have received, say, either a BCG or a OPV or some other vaccine, but not DPT vaccine.
And do you have, sorry, Justin, the microphone. Yeah. Do you have any perspective on which one of those has potentially like a better kind of it's a better opportunity to start with? Like, is there kind of a ANC or like a nutrition? What's the highest impact in this coverage overall, or is it the other vaccines in general?
So it depends from country to country. Like I had this slide. So like in Nigeria, institutional delivery was coming as only 14%, 15%, but the ANC is higher. Other vaccines are higher. In Ethiopia, it is ANC alone that contributes, and then vitamin A. So the contributions vary, and because on the program maturedness, some places you may even look at malaria program, you may look at HIV program if a linkage can be built. Polio programs, because polio is data is not separately available on DHS. So this is a preliminary exploration, gives a hope on how you can identify children. But then this will have to be, and I realize that I don't know the context in half of these countries, and this will have to be contextualized, but there's a line of exploration that others can adapt and design their own programs.
Great, thank you. I think this is a great opportunity for us to learn more about and try to understand that from a portfolio perspective. Mira, I think we can come in for some questions from the room and then come back to the virtual environment. Mira, please.
Thank you. Congratulations to both of you. For Deep, we always share a lot of interests and we're anchored in the same place. So actually just a suggestion, which is, so you're saying that health workers should use their data better. And that's clearly true. But if we can get to just giving them the names that they, in a stoplight format, green, a clinical decision rule, which highlights those who are more at risk, it'll be much easier for them. So we should think of going in that direction if we can and making it easier for them, even if we don't give them an app right away. So our subnational modeling suggests, so by states, there's a little bit of a difference of how you would weight things, but the variables that you named are the variables. And you don't need a lot of additional information besides you would get vitamin A and other vaccines from your normal vaccine information. You just need a bit of information on place of birth and number of ANC visits and maybe 1 or 2 other things, but that would give you a pretty good prediction rule. So I think
that's if I may come. Because this is what I wanted Mira to say. This was not pre-planned, but then of course, see, earlier today you mentioned something about preventing zero dose. So for those of us on the implementation side, as you rightly mentioned, 12 months is too late to intervene. So practically we need to work on everyone, unless there is a system that predicts and tells us this child is probably a high risk for zero dose. Be it an ANC period or early childhood, we also do home-based newborn care. So there are multiple opportunities, but if a prediction model can reduce that burden, because we are actually, when we are implementing on the ground, we are working towards preventing zero doses because we can't wait till 12 months. And that's the reason I think you are receiving a lot of questions on what is the definition of zero dose, because everybody who's actually implementing for them 12 months doesn't work, right? So thank you, Meera.
Sorry, just taking the opportunity. I also wanted to say that although I really loved the factors that Tove and Mike were drawing our attention to, I felt that Deep's presentation called us to think about more factors. So for me, a gender lens is kind of good and kind of too easy. The example that you gave about Vinita, the health worker working in a minority community, that you were interpreting as how hard life is for Vinita, the health worker, but it is also hard for the community. And there's a reason why she, as a part of the majority, has the job that she has. And we have to, and she also has an identity which is more complex, which has other factors on the list too, as we all do. We all have complex identities. So I think, although I love the starting point, I would really love to see it move into a more complex lens, because I think without that, we won't understand the local important factors, and we won't be able to tailor interventions that really address what's worrying communities.
Thank you, Meera. Judith.
Yeah, thank you so much. Terrific presentations. One of the things I've been thinking about is the idea of the identifying, and like you're saying, 12 months is too late. And we know from other areas of the health system, like family planning, for example, that ANC is an excellent place to build rapport with a mother for services postpartum, like family planning. And so it would seem to me that when we know that there are certain features, maternal features of issues in terms of access to care and gendered issues, et cetera, that is also a perfect first stop to build rapport, to first identify women who will end up having zero dose or under immunized children, and to start working with them to build the rapport with them, their husbands, et cetera, mother-in-law, and so on, to then move on to postpartum care for the child and other children in the family. So I think that's an area. And when you talk about ANC, Deep, I didn't remember, you mentioned that some of the countries had very high ANC. And so again, to me, that is a very nice first stop.
This is great. Yeah, thank you. Heidi, please. Oh, sorry.
Thanks. I think I want to make a comment a little bit on some of this theme around complexity. And I'm having some thoughts gelling, especially since we're here trying to think about recommendations. And one is I want to just think, I want to acknowledge that I think the work that was being pulled forward here today, that I think was exemplified by what Tove is, what you put forward, but also what we're seeing in the learning hubs, is that, you know, there's an evolution of and an improvement on some of our frameworks around zero dose and a determinants of immunization that I think will take us that much further into 6.0, really understanding what we need to be looking at and how those factors interrelate. And then, you know, this idea of like multiple deprivations over time, and some of these communities are really suffering over time, you know, that will help all, you know, us determine what, not us, you know, I'm using big us, what are the right interventions, you know, for particular communities at subnational areas. And that really has to be done at that targeted subnational area. And it's going to be, you know, as we've been saying, unique, sort of almost community to community. At the same time, what we're seeing is that some of these zero dose children are, as a result of some of the shocks, the system. We know that from COVID. We saw that in the Bangladesh learning hub, the supply shortages have shifted the landscape. We saw that in Grace's presentation, I think it was from Mozambique, about the health worker shortages, and that those reasons for being zero dose are going to result in different interventions. And, you know, maybe it's a regular sort of catch up. But if you go back to the frameworks, like they're still going to be causing probably distrust in the health services, or, you know, so we have to go back to those underlying factors, because a catch up may be what we need to get a lot of kids, but maybe there was a lot of distrust. So we have to keep that complexity in mind. And I think, and even what you were showing, Deep, is that, yeah, they may have been contacted by the health workers in an antenatal care, but maybe it was a negative experience. I'm sorry, I'm using that over and over, but the point is that there are reasons and they're complex and they influence each other. And I really I'm appreciative of how this evidence is coming together to sort of improve our frameworks, even about how we're thinking about it, and can study it better in the future. So thanks. That's more of a comment, but happy to hear reactions.
So while I agree that there are a lot of complexities that are involved, but it's what we are finding, and this is something that we have just worked upon, and the drivers we have when we have gone back and done actually those consultations. A lot of effort went in, like around, I think, over 80 IDIs and over 300 zero-dose families visited to understand why didn't they go for immunization. During ANC, there were, at least in our context, in UP, because that work is limited there, was not as much as a poor prior service experience during ANC, but a lot of it was, as I was mentioning, prior experience with the previous child who got fever and other things. So those AEFIs are kind of playing out a lot. And the second thing that, unfortunately, like this is what we are seeing in UP is families saying no one contacted us. So they have become so dependent on ASHAs to come and contact them to come for vaccination. So if ASHA misses going to a family or does not go to a family, that child is kind of going to miss immunization. Most likely that the child is going to miss immunization. So there are many complexities that are involved even within that fever. So fever leading to loss of wages, fever leading to angry husband, the fever leading to grandmother or the mother-in-law not like harassing her verbally or other ways. So there are multiple things within that fever as well that affect. So I do agree that these are complex things, and at least in UP, and because it is last 5%, 5 to 7% that is left, what we have kind of realized is the solutions also, the interventions will have to be tailored by the family and not by geographies. Because within the same village, if there are 3 different families, all 3 have a different reason. So these are very highly individualized reasons that are leading to zero dose, at least in our context. And this is what we will see as other geographies also mature and the coverages increase. So when we are in the last 5 to 10%, this might be what we see other places as well.
I see a lot of value on the ecological logic. Like I think there are multiple factors that probably are common to the community, and some that are specific to each family, and we need to think about that very clearly. I agree. I think what you're showing is a good kind of a platform. I like what you said about maybe the denominator of the API program is the numerator of another program, and people keep talking about, oh, we have a denominator issue. This gives you a platform for community engagement, for engaging with this family. The how needs to be reflected in a contextual manner. And I think this is what connects that with the TOV learning agenda on the why and the human-centered design and trying to understand the root causes, because that's going to help design the program. But I think there is a lot of intersectionality between these two approaches. Just wanted to flag that as well. I'll come back to the virtual environment because we have a lot of questions coming again. So one question is to Mike. You mentioned that it's easy to write in gender into a program, but much harder to operationalize it because it's not a must-code people are used to use. What do you think is going to take to get people to use that must-code?
It's a great question, and I hope we find out some of that. I know that Gavi is deploying a bunch of gender TA. I know lots of partners have been more intentional. Certainly governments are getting more used to the idea through EIF applications that this is an area to focus on. I think all of us are wrestling with how to incorporate gender into our actual programming. We can be intentional about looking at the issues, but many of them are socially derived and based off cultural norms and things like that, that Gavi and a health program will struggle to change. So is it accommodating them? Is it adapting our programming to anticipate those issues? I think that's the kind of thing we are trying to figure out. So it does fall at that intersection. Right now, what I would hope to see, like in a country that I think successfully tackles gender in the EAF, what we would see is people revisiting that question. Are we understanding more about the issues being faced by women or whatever gendered aspects of the health program are being experienced? Are we coming up with ways to tackle them? If we're finding that husbands are not giving permission, are we understanding what it would mean to empower women to make those decisions or to engage with husbands on those decisions? Are we treating gender as a problem that we can engage with? Or is it something that we just look at and don't touch? So I think that training that muscle is getting people comfortable with the idea of bringing that lens, finding ways to constructively engage with it and understand what those type of interventions can look with. And to a certain extent, bringing technical support and frameworks and a way of working that allows that conversation to occur. That kind of intersectional approach was not common in, I have a degree in history. Like it wasn't common in history studies like 30, 40 years ago. It's now pretty normalized. These are things that change within fields of study and work. So this is a step on on a journey. It's not something we're going to see overnight.
Yeah, thank you. Just to complement that, I think we did an evidence review of one gender strategy, which the leveraging women's group. There's a lot of evidence coming from Mali as well on that. And that one, we kind of saw very positive effects in health outcomes in general. Not a lot on immunization yet, but indeed a lot of like good health outcomes in other areas. So that's something that we know is promising. The others, I'm not sure has been any kind of a evaluation yet with this kind of a gendered approach. So the next one is it's more a comment, I think, for Deep on like the missed communities and missed opportunities. And the comment is that why do you think there is? I think that there is a kind of the question is trying to make an association between that and the fact that the quality of the data may be poor to kind of use that and relating that again to availability of staff and overburden to do the mechanical work. Do you think that plays any role, like or in the Gates learning agenda? Is there any kind of a reflection on like the causality, the root cause, bringing that back to kind of the lack of staff and the overburden impacting all this kind of a data quality and use and being able to do that that links between the PHC integration?
I mean, I can answer that a bit generically. I think certainly, as I mentioned, we're still in this phase of our work, but the pushing beyond just the driver and really trying to get at the why and the root cause is a core part of our work. And I didn't mention it in our sort of review of what's working well and what's not, but I think that in our experience, that's not always straightforward, and that like trying to sort of push beyond the surface level is, I think, taking our grantees more time and effort and focus than we had initially anticipated. Gus, I feel like the question was really focused around kind of data quality and data quality as a root cause. Is that?
From what I got, it's more kind of about bringing the root cause, like it was like that issue of PHC, is that related to data quality, and is that related to overburden health staff because we don't have a lot of them? So I think that logic of thinking is something that is being suggested, and also like trying to bring that back to HR. I think the concern is more related to HR in the question.
So
I think it's the correlation between what Heidi was suggesting on a health system from the ecological model, like a health system barrier leading to these other components? And do you think that plays out or not?
So in the context that we have tested it, there was by and large no dearth of community health workers. And I think that was also an abstract that was submitted, and we were able to, and we validated that as well. So while there is definitely a data quality issue in health worker records as well. And that's the reason one of the suggestion was designing better records, which are easier to use, because right now, even if somebody asked me to fill it, I wouldn't be able to. And but then again, we were able to identify 70% of the zero dosers just using health records maintained by frontline health workers. So 70% of the zero dosers using paper-based records we were able to identify. And this was done in 4 blocks, so around a population of 1 million. So our field teams did this thing, validated in a sample of the area, and the final result was 70% of the children or their mothers were there in the records. So there was junk data as well. So because it happened so that the children were there, but their records were not updated, and so we misidentified some as zero doses. During validation, we found that actually they had been vaccinated. But then the scope is there, and that's the reason, while digital systems were the third recommendation, but digital system kind of makes it easier to track rather than a paper-based one. Because here the idea was the community health worker would have service delivery updates, whereas she doesn't do any kind of service delivery. The service delivery is actually being done by a vaccinator or an auxiliary nurse midwife. So her data might be updated, but not with the same information is not available with the community health worker. And that may have led to those errors. We still have to go into the reasons behind it, but we had done this exercise in UP at least.
I think there's a lot of comments on validation of this kind of a missed opportunities approach, and in general, I think people are excited on that in the chat. There is one question from Mandar on if you did any kind of analysis on the correlation between seasonal variations and geographical areas on the prevalence of zero dose families, and is that a barrier? Like, how do these factors influence vaccination uptake and access to healthcare services in underserved communities?
All of these were like, we used either DHS data or even these were all, so there was no tracking as such which was done. So we don't have seasonal data or anything to do that analysis.
We at the Learning Hub in some countries we have some of that, but it's in some months that you have like lower coverage that tends to be like catch up in the later month. I don't know what's the impact of that in a kind of a portfolio level. I know it's there in some of these underserved communities, but I don't know what's the impact also like in the general results. Anecdotally, we heard stuff and we see like some reflections in the coverage curves in the ZDLA in Uganda specifically, but we don't know what does that actually means in the overall result of that. Something for us to keep in mind as well. Then I think there is another question on the advocacy work. In applying the IRMA framework, there has been relatively little attention to the advocacy. Yet this is an essential bridge to go from identifying to reach missed children and communities. It requires resource and political will, which sometimes is even the cause that children are missed. Can the speakers give examples or say more about how they are addressing advocacy in their work? I think overall in the ZDLA, like, is there any kind of a specific targeted work for the advocacy?
Yeah, I can speak to that. We don't have an overarching, and actually I almost commented on it on our slide where we talked about our motivating hypotheses. We also neglected advocacy as a part of that. But it is certainly a part of how we are thinking about our grantees' work and how they're engaging. So as I mentioned, each of our grantees is working closely with government and with other partners to think about how they can bring forward what they're learning and link it with others in the area in order to try and sort of build both the collaboration and coordination, as well as expanding political will and hopefully potentially identifying new resources. So it's certainly a part of how our grantees are engaging.
Anyone else in the room wants to talk about advocacy in their projects? Closing, please.
Yeah, I can certainly chime in on that. I think from evaluating a couple of EAF applications. Can you hear me now? Oh, yes. So from evaluating a couple of EAF applications as well, I think like Mike was saying, looking at the application phase and looking at, the effectiveness of the interventions that are outlined in the proposals, I think there are a few promising examples that did come up in a couple of countries. So a good example is from Uganda, where we have working with the mining companies, where the EPI essentially has included plans to collaborate with mining companies and communities, zero-dose communities in those environments to be able to better reach, work with the companies to reach zero-dose kids. Similarly, in Cambodia, we're seeing a lot of really great examples working with just organizations, big companies that are in that environment, banana plantations, and essentially leveraging the reach of these organizations to be able to further penetrate this community is something that we're exploring. And we're also thinking about how we can document some of these really exciting examples. In addition to that, we're seeing in DRC, as a good example, the use of domestic resources and essentially coupling that together with what Gavi has put on the table for zero dose, and essentially having like specific districts in DRC who are putting money down, the government's money, down towards reaching zero dose. I think those are some of the promising examples that we started to see just from looking at the EAF. But I think there are many other examples that I think we can continually use to inspire, advocacy and what zero dose advocacy could look like.
Thank you. Yes, Mike, please.
And I think it gets to one of the things you said earlier, Gus, is one maybe turn that we need to change on the advocacy piece is I think we sometimes articulate it as like zero dose is important. It should be a priority. We could probably deepen that definition of what the advocacy work is in IRMA. Is it sourcing funds? Is it asserting the visibility of community voices or particularly missed communities? Like there are probably 3 to 4 particularly high aspect elements of advocacy that if you'd called them out as the highlight sort of pillars of advocacy work, that it would drive us towards more specifics, that it's not about simply making zero dose visible and a priority. There are lots of health priorities and vertical programs always scramble over each other to climb to the top of that pile. But it is to say, it is securing budget for the additional cost associated with zero dose. It is recognizing which communities are systematically missed out in a country and that kind of thing.
And if we get to that level of definition, probably we can also evaluate how programs are doing that well or not, and understand what works in this setting as well. Who is first? I don't know. Like Grace, please.
Thanks. Just building on that question about advocacy, I mean, I was going to say I would advocate for making that definition something applicable at a subnational level, because as much as I've worked on the financing question with Gavi and know how it's evolved in terms of how we think about financial sustainability. It's been so focused at a national level and on vaccines, and vaccines don't deliver themselves. We really need operational costs at some national level, and we need some way to promote that, to mobilize that, and to monitor it. It's very, very difficult to monitor, even for people in country. They have no idea what one district is spending on immunization versus another. Stop there.
Sunita, please.
Yeah, so advocacy, when we look at the abstracts, it's very clear that these are ad hoc events. They are generally connected with the campaigns. So when we don't do advocacy in a consistent manner, and when we don't monitor the advocacy that we do, that's why we keep running into trouble. Then we don't have the data to substantiate what we did and what would we get out of it. So I will link it to some of the comments I had, and very quick ones, Gus, keeping an eye on the clock. One is if the advocacy is related to the concept of fever, which is coming up so often. Now imagine in a low literate I know the word low literate sounds terrible, but that's a word used in the literature. So low literate population, when they are unhappy with fever, imagine if that is for the minor aspect, okay, AFI. What would happen if they understand there are also moderate and severe AFI? All hell will break loose. So if we don't advocate and if we don't talk about AFIs and we just assume when it happens, we'll deal with it, that's going to be a problem. So advocacy is required for dealing with AFI. Secondly, related to that is pharmacovigilance. Right now, in all the low and middle income countries, we have pharmacovigilance, which is a very passive approach. We expect a patient or a vaccinee to understand that pharmacovigilance happens and there is AFI, and then they should come to the PHC. How much are we expecting here? So that's something we need to think hard about. So advocacy is required there. Mother and child protection cards are in most developing countries. So if we are not able to advocate for the filling out of those cards to be appropriate and to be monitored, we are still losing ground on that. And most important, if we have to learn from the best practices of how gender has been embedded in any other program, forget immunization, because Mike, you brought it up, HSS. If any other program has embedded gender and power dynamics in a much better way than we have learned to do it, then it's time to look at what have they done better and what do we need, because we know what we need. So it's about cherry picking again. So all linked to advocacy. And back to you, Gus.
Thank you, Sunita. This is very useful insights from the abstract as well. And there is one question here that actually I can probably split that into. One is that probably the factors, the time away from work, the pressing tasks, the costs of like the hidden costs for immunization, they are common among many PHC services. Can we think about like how to collectively kind of solve those issues like in a kind of in a more integrated way? And then the other question that is it's same the question is a follow-up question. Do you think like it's more about like verse between what should we do? Like, should we try to remove those barriers, or should we actually try to do more outreach and try to reach these children with like more supply-sided interventions? I don't know if Gage would like to take a.
I can take a first pass. I think that there are certainly ways that we can think about addressing those opportunity costs in a way that's more, I think I would say we talk about like person-centered healthcare, and I think that it also is very related to gender issues. Like, how do we basically revise the way in which we are providing services to make it more amenable, and that, is it one stop where you can get a integrated package of services? You raised the second question here around, do we begin to remove those barriers, or do we take services closer to communities? I think one of the other pieces that is coming up a lot, and it was mentioned related to Nigeria and the new incentives, or do we find ways that we compensate, incentives being one of the key ways that we use to kind of mitigate or reduce those barriers that people have seen. I think that there are a lot of different ways that you can go about it. I know that from our research, several of the caregivers talked about themes of bring services closer to me and bring services at times that are more amenable. And so I think that, I guess I think of that as part of a broader making PHC services more user-centered.
Audrey, please.
Thank you. It's not so much of a question, but more of a reflection. Just going back on and picking on a few themes, and I've been thinking. So the service with all these zero-dose children families and this and with that contact with the services, and it links back. And we were talking about the healthcare workforce being overburdened, and really I think it's just a matter we need to, and we talked about earlier, capacity building. I think we need to give space and resources and time for healthcare providers to, when they have, you know, a family, let's say a mom visiting for antenatal care, and she's visiting with two of her children, then it's like they need to have the time, but also the training to train them to think of all, not just responding to the pressing need and reason of visit, but like, oh, since we have, you know, why don't we check the vaccination status of your children that are with you or that are not with you? What are the other needs? So, and also it's a matter of, yeah, giving them time, resources, but also training of assessing and responding. So, and I think it comes, and the interpersonal communication skills of knowing, you know, tricks on how to address vaccine hesitancy, like motivational interviewing, and how we can actually reassure regarding AEFI. Sorry, I've been saying it in French in my head, so thank you.
We're getting close to time. There is a broader question unrelated to the programmatic components. What can donors do to better fund and scale effective interventions? We know the barriers, we know the intersectional elements, what needs to change? This is an existential question, I think, almost.
I mean, I will say, again, we didn't present on any of our findings related to the reach or the intervention part, and that's because we're not there yet. But I do think that one of the pieces that we are attempting to do as a donor, and would love feedback, but I think trying to implement in a bit of a different way that is really driven by community voices and community perspective, and being really listening to those and having those feed into what are the interventions. And so I'm hopeful that we are certainly not going to do it perfectly, but I am hopeful that we're moving in a direction that maybe is a little bit of a different tact. And I talked about that, like, you know, to date, a lot of interventions are much more of sort of a top down. And I think that that's been really effective at reaching the vast majority of children. But I think to reach these zero dose, we do need much more of a bottom up, community driven. And part of what we're trying to do is test how do you do that at scale, or how do you do that across multiple locations? And so I would say we're testing that and trying, and I'm certain that we will fail in some ways, but hopefully they will have a few successes.
That's great. And to some extent, in the Gavi 6.0 principles, we said like Gavi needs to continue being country owned, but also very much community driven. But this is still a principle, something that we need to understand how to do that better. Grace and Hope, and then we close because we are already over time.
Thanks. I did want to just sort of jump in on that comment. And, you know, within MRIGHT, we totally believe in how important it is to engage the communities. We work from the community up. But I think at the same time, and I thought of this more as we were talking about gender, we talk about all of the gender barriers from the caregiver side. There are gender barriers from the health worker side within the health system. I mean, you're more likely to have vaccinators that are women. They have male supervisors. Their safety is over, you know, there are different situations around their safety, their authority. Their needs are not met, you know, when they're voiced, because it's just some woman, you know, far away, you know, complaining. So I think all those things we really do need to pay attention to when we talk about gender, you know, in addition to all of the community needs.
I think the question on what we can we do, I think that's what I've been going through this. I keep coming back to this, and I think it'll be really important how we approach tomorrow and the recommendations. And I think starting to tease apart kind of, you know, what is really immunization specific versus kind of broader health, you know, who needs to act, you know, is this the researchers, the implementers, the funders? I'm looking at Logan thinking about, you know, we had convened a big thing on value vaccines, you know, like 12 years ago. It was like one of the first things I started on. And what was really useful when we came away from that was having a really kind of concrete list of things for who can act. And so just to say, I'm kind of thinking about that with a lens towards tomorrow. You know, for us, you know, we've got a few key levers that we can do. We have collaboration and being able to catalyze others with our advocacy that we do. We've got clearly funding, so what we fund and you know, the principles and the approaches to that.
we can, fund some evidence generation and try to support some of the use. We don't have a huge amount of funds for that. And then we have our application review processes, which I think are a really important lever. And so I think I keep in my mind, keep coming back to, okay, which of these things would kind of go into those different kind of buckets for us and start to shape some of that. I think it's really timely because we've got the health systems strategy. But I am kind of, overwhelmed at both the size of the issues and then the how local the issues and coming back to the sitting in Geneva thing and trying to think about how best we support that. And I think some of it is, if I think about where we landed at the end of Gavi 4.0, and how much we've already progressed, just seeing all of this. And so I wonder if it's then coming back to some of those, basics of how we support countries to be able to develop those plans, to look at their information, to better tailor those things, and then how we play this role of funders and being able to help institutionalize and both make available that support, but then institutionalize. And it comes back to some of the kind of norms and guidance too. So how we turn this into a little bit more at scale. So I also kind of keep bringing back to scale because I think that's one of the things that Gavi is most useful for. And so that's kind of the way that the different buckets my mind is going towards, but I think tomorrow will be a really important discussion to help us progress on that.
Thank you, everyone.